Welcome to the BCEN and Friends podcast, where we hold interesting conversations about learning with a range of thought leaders, BCEN certification holders, and industry professionals. Our goal is to create value and insight for you, our professional nurses across the emergency spectrum. We hope you find our discussions interesting, informative, sometimes funny, sometimes serious, and always worth your time.
Welcome back to part 2 of our CFRN Roundtable. We're diving back in with our powerhouse panel of certified flight nurses, Jonathan Baxter, Caroline Levin, and Jacob Miller. Each brings a wealth of experience, sharp insight, and real-world wisdom that's sure to spark your thinking and keep you engaged. So buckle up, because we're continuing the conversation. Get to the chopper.
I want to jump into a scenario that maybe encapsulates a lot of this conversation, whether it's safety in the aircraft, whether it's, the jump bag with the 3 things on the deserted island, or being able to adapt. We have a hypothetical scenario again, and let's just say that you're all in some way involved in this patient's care and transport, and would love to hear some of your thoughts and opinions on taking care of this individual. So the scenario is that you're called to the scene of a patient involved in a motor vehicle collision that is extremely diaphoretic. They're anxious on scene. They're having difficulty breathing and flailing their arms, stating that they're in severe pain. And certainly this sounds like somebody that we could transport by ground, but the ground crew called the helicopter because there were other fatalities in the vehicle. The patient has an obvious femur fracture, possibly some thoracic injuries, and just the mechanism of impact, the fact that there were other fatalities, significant bruising across the chest and back, and the way this patient's acting, the ground crew felt like having some more experienced providers was probably the right call. So they've called you, and despite the injuries, the patient insists he cannot go by air. He's afraid of heights, but in the middle of all that, he's still saying, I can't breathe. So how do you juggle this patient that is clearly needing clinical care and they need the expertise of the aircraft crew versus the patient that says they can't fly, and you're like, look, is this person even cognitively aware of what they're saying? Are they even able to make this decision at this point because of how significant the impact was and the other fatalities? And so this gets into this scenario of the ethics of flight, and I'm sure each one of you has had some similar experience before. How do you deal with that? Maybe Jacob, will start with you.
Yeah, so the first mantra here is that, remember, every competent patient that you have is allowed to make stupid decisions. So if this person is awake, alert, oriented, has good insight and judgment, which it doesn't sound like, but hypothetically, right? We have been called to those patients that are like, I am not going in that aircraft. And they can articulate what the risks, what the benefits, et cetera, are. Patients are allowed to make their own decisions. They have that autonomy principle. That being said, this patient doesn't sound like that. So I think that now what we have to do is we have to weigh and obviously it depends on where we are, right? Because we get called sometimes, even in the greater Cincinnati area, we have like the 275 loop that goes around the entire city. So we know if we are going inside that 275 loop, like closer to downtown Cincinnati, it's usually because of severe injury where they want that higher level of care immediately on scene. It's not really a transport thing. It's a person thing. It's equipment and resources that we bring. Versus out in some of our rural counties where we go out there and it's more of it's an hour and a half to the trauma center, and this patient can fly and be there in 20 minutes, 25 minutes. So which one of those are we dealing with? Because that may affect my threshold for dealing with this. If we're inside, we've got a relatively short flight to a capable trauma center, and or a relatively short ground transport, I might not even argue. I might be like, okay, cool, we're going in the ambulance, let's go. We'll just roll there and the pilot can meet us at the hospital and pick us up. If we're further out and it's like we're looking at 20 minutes versus 90 minutes and this patient is clearly in extremis, I think then we're having to look at, okay, the next factor that plays into this is, can I safely put this person who's agitated, flailing, not following, not redirectable, not following direction, can I safely take this person and put them in an aircraft? And depending on what airframe you're flying in, I mean, there are some HEMS airframes where that patient now becomes your co-pilot, quite literally. One misplaced leg and they're kicking the flight controls. So depending on the airframe, depending on your ability to package this patient in, but it doesn't sound like this is someone in their current state that I would be comfortable taking into my aircraft. So now we have to consider, what do we do about this mental status? Is this something that do we have other indications to maybe RSI this patient? Is this someone that we can do some sort of sedation on? If you have that in your protocol in your system, either amine or droperidol, haloperidol, benzodiazepine, whatever that might be to calm them down first. If you're looking at that, now I'm weighing risk benefits of not only the transport itself, but also trying to figure out a way to manage that patient's psychomotor agitation. So it then kind of dovetailing off of the last question we were talking about earlier with safety of flight. Now I'm looking at, is this a safe patient to transport by flight in their current state? And the answer is probably no. So what do we do about that? Those are just my thoughts. I'll defer to someone else for the answers.
No, and there's not an exact answer at the moment. The scenario will definitely progress, but Jonathan, we'll jump over to you next. Any additional thoughts there?
Man, I think Jacob really knocked that out of the park. That would definitely been my suggestions as well, being like, well, if ground transport's an option, the patient's just really determined that they don't want to be in that aircraft. And if they're going to fight me the entire time and make it unsafe, then definitely ground would be the way to go. Like, kind of when it comes to making the patient being able to make autonomous decisions, I kind of go back to the Emergency Nurses Association kind of stands on C collars. Like, are you ANO times 4? Okay, you are. You have a GCS of 15. Are you under the influence of drugs or alcohol? Like, I try to make some of those judgments, being how confident is this person to make this decision. And then I get down to these femur fractures and things like that, where they have all of these distracting injuries. And so now that we have distracting injuries, is this patient able to make a confident decision, even though they are awake and alert? And, I would try to rationalize with them. It's pretty interesting. Like, I had this exact scenario happen to me when I was in orientation, my second or third flight. It was like an 18-year-old kid, and they were flying an ultralight little aircraft, like little parachute thing. It's got the big fan on the back of it, and they were cruising around like 1,000 feet, and it had an engine failure and crashed. And so we rendezvous with this ground ambulance at the airport. And so I get in the back of the ambulance. It's obvious bilateral femur fractures. The kid's awake and alert. It's got pretty good vital signs and stuff. Doing some IVs and doing the things. And then as soon as we open the door to the ambulance and he sees the helicopter sitting there running, absolutely hasn't come apart. Like, he was not interested in getting back at anything and going 1,000 foot in the air regardless. And so we had to put him back in the ambulance. And we wound up sedating him, getting him calmed down to where he was upset. But it was a really significant transport delay for this patient to go back and do this. But we were, 90 minutes from a trauma center by ground. It was far out in the middle of nowhere. And so when I saw the scenario, I was being like, dang, I've seen this play out before. But yeah, I think it's interesting. It's not a very good clinical picture for this person. Definitely not.
No, Caroline, any other additional thoughts on this?
I mean, I fully agree with Jacob and Jonathan. I think you have to look at your resources, see how far you are from a trauma center and things like that. But as someone who, I don't want to say I made nursing my personality, but like, nursing is my personality, right? Like, it's my career choice. It's what I love to do. And I think when you run into patients like this and you come across patients like this, I first and foremost, we'll go back to the basics, right? I get into the back of the ambulance and there is a very anxious patient who is a polytrauma, flailing, very upset. There's maybe 2, 3, 4 other providers in the ambulance. If you haven't done anything to contribute to that care of the patient in the last minute and a half, I need you to step aside. You go up to the patient. My name's Caroline. I'm a nurse. I'm here to take care of you. I'm very worried about your injury patterns. And then I start treating the patient, whether I'm going to go by ground, whether I'm going to fly, whether I may turn the care over to someone else. I want to treat that patient. And maybe you put the blood pressure cuff on and the pulse ox on, and you find that they're hypotensive, hypoxic. And maybe this is all just what I like to call the hypoxia itchies, right? Like, yes, you're anxious because you're traumatically injured, but you're also not perfusing well, and that's making you more anxious too. Maybe we start resuscitating you, we throw a tourniquet on, we get your blood pressure up, we get more oxygen on board, you start to calm down a little bit, you become a little bit more rational. I think we get so caught up in the, like, do the cool thing, put them in the helicopter, get to the chopper, like that kind of stuff, that we lose sight of how many times I've watched somebody get into the back of an ambulance and they don't even tell the patient their name. And then you're supposed to come across a cornfield into a running helicopter, fly across the sky into a trauma center with me. Like, of course you're scared. And I think a lot of times just that base level nursing compassion can play a huge part in, I don't want to say making a patient compliant, because it's not about forcing a patient to do anything. I want to do what's right for you. And if that means talking you down a little bit by giving you my perspective of the honest opinion of, I'm worried about you and I want to take care of you to give you the best possible outcome, sometimes that can really help just ease a lot of that anxiety. Start your resuscitation and go from there.
That's a great point, Caroline. I think making that connection is extremely vital. And I think it's one of the things that we as an industry still really struggle with sometimes, is forming an immediate rapport with the patient. And so I think that's a really good point. All of you, excellent points with that. And let me make it a little bit easier and just say you have started to form this rapport, but as you're doing so, the patient becomes unresponsive. So you're not going to have to worry about possibly transporting the patient against their will, because now they're unresponsive. Clearly, they need to be transported. They do have a weak pulse, and you immediately intubate the patient still in the ground transport vehicle, but you obviously need to fly them. It is a long distance to the trauma center. So, but again, they've had significant mechanism of injury. The ground crew has mentioned that they have a lot of bruising across their chest. So, getting much more to a focused clinical kind of picture here, what concerns do you have now that you've intubated them and you have to administer positive pressure ventilation? So what are some of your concerns now that you have taken control of their airway? What do you do next? Caroline, I'll go back to you.
I mean, I assume at this point that I have some vital signs and I've assessed my patient as well. But first and foremost, I'm concerned blunt chest trauma, multiple fatalities in the vehicle. Am I dealing with a hemothorax, pneumothorax? Does this patient need decompressed? Do they need a chest tube? Obviously, you don't want to give positive pressure to somebody who's got a pneumothorax, increasing that intrathoracic pressure and potentially making things worse. So looking at my vital signs, am I hypotensive, tachycardic, hypoxic? Is my patient potentially in peri-arrest, going to arrest on me in any second? Maybe they just get decompressed simply because they're in a peri-arrest state. So I want to get the full picture of what my vital signs are telling me, what my assessment is telling me. And I certainly don't want to go up on my positive pressure ventilation without addressing the basics first, making sure I don't have a pneumo or a hemo.
Yeah, and Jonathan, anything you want to add to that one as well? And I will give you vital signs at some point, but at this point, anything additional there?
Yeah, no, I think Caroline nailed it. I would definitely be worried about exacerbating an underlying condition like a pneumothorax or a hemothorax, or maybe some sort of bronchial tracheal disruption that could really complicate the course, where instead of making the situation better, it just acutely got a lot worse. And so going back to the basics, going back to resuscitation, H's and T's, like that's what kills people on the side of the road. And so I definitely would be really you'd be really assessing for that. I think protecting the airway is something you got to do. I wouldn't not intubate this person who was trying to arrest on me, but I would definitely have that concern that this could be a lot worse.
Yeah. Well, Jacob, I'm going to ask you if you have anything to add, and then maybe let Holly do some more diving into the scenario. But anything else you want to add, Jacob?
So yeah, I think we have to look at that primary survey, right? So in your primary trauma survey, if you haven't made the switch over from A, B, C, D, right, is kind of the algorithm I use in MARCHED, MARCHED, right? So M is your massive hemorrhage. This guy's actually got a lot of contusions. He's now presenting unresponsive with a weak pulse. He may not have massive external hemorrhage where he needs a tourniquet, but it seems like this is someone who may have a massive internal hemorrhage where he is at risk of hemorrhagic shock. And to the point earlier, this may be something where actually before we dive right into the A, which is our second thing, our airway, it may be prudent to initiate some blood product resuscitation. We don't have vital signs yet, but guess what? He's got the mechanism of injury, he's got physical signs of hemorrhage, and he's got a weak palpable pulse, which tells me he probably has a reasonably low blood pressure. And I'm going to surmise, although again, we don't know it, but just palpating that weak pulse. If that weak pulse is relatively fast, guess what? We've got an elevated shock index. So right there tells me we can probably just empirically begin some blood product resuscitation, throw some TXA in there if that's in your protocols. That's not going to be an immediate fix, but that may help down term. But definitely begin that blood product resuscitation if you have that available to you. And that actually, if you do that, I have seen patients that have drastically improved their mental status just from giving them blood back. So we may actually be able to resuscitate this patient and not resuscitate before we intubate. We may be able to resuscitate and then not have to intubate. But if we've already done that, maybe we pull the trigger super early or whatever, we tried it and it didn't work, and now we have that intubation going on. I mean, absolutely. Everything that everybody has said, I'm certainly concerned about intrathoracic pathology. I'm certainly worried about, the decreased venous return. I'm more worried about inducing a tension pneumothorax. All of those things are absolutely on the table that all my colleagues have mentioned here. But I'm also worried about, we discretely look at A and R and C, airway, respiratory, and circulation. Really, all of those, as any good experienced clinician knows, like all of those things interact with each other. Right. So my MARCH is massive hemorrhage that's immediately controllable, airway, respiratory status to include tension pneumo, hemopneumo, those types of things. C is for circulation. H is for, head injury. Is that something we have to be protective about? E is for exposure, both A, to look at the patient, and then B, environment, to make sure that we're not causing them to get hypothermic, because that's bad in trauma. And then D is for dextrose, because I think that's actually one thing we haven't mentioned yet. This guy who's wildly agitated. Caroline did a great job with hypoxia, but also this guy could be hypoglycemic perhaps too. I have seen that occasionally where patients get hypoglycemic and they suddenly get like this fit of rage. So, but all of those things we want to consider with this patient, but common things being common. Biggest things on my concern are fluid hemorrhagic shock and then intrathoracic pathology that's going to be a problem for this guy. So those are my concerns after we've intubated him. We're just kind of in that peri-intubation period.
Yeah, I think you guys all made great points. And I do agree that however this guy's mental status has obviously declined, it could have just been anxiety, but it could also have been from hypoxia. It could have been that his sugar's low. He's hemorrhaging. Obviously, he's got some blood that is not where it's supposed to be, right? So the idea is that he has a multitude of reasons why it looks like he's decompensating. I mean, we do want to jump in and, yes, secure his airway, but kind of just thinking through all of those things, because again, I think as someone that's faced with a problem, we always want to do something. Like we want to do an action. What is it that it's that action bias, right? Like we feel like we must do something. And so some of the hardest things to do is to like pause and go, okay, is what I want to do, is it the best thing to do for this patient? Is it the most appropriate thing to do now? Because I think all of us, whenever we start in whatever specialty of nursing we're in, everything is new and everything is like, oh, this is what we do. And then as we get further along, we realize like, oh, we do this for almost every patient, right? But is it the right thing to do for that patient? And especially when you step towards those procedures and those interventions that really can cause a different outcome than what you intended to do. And I think that kind of is where we're at. So this patient, hypothetical patient, was intubated, but now we have some other concerns. So again, anything, would you want to add something, Jacob?
Yeah, I'm thinking a lot of folks look at expanding scope of practice and getting additional training and education and everything as exactly that, expanding your scope of practice, being able to do more stuff. But I think like the more knowledge, the more experience you have, exactly to your point, Holly, like that's where with experience comes the ability to recognize that maybe you couldn't do some of the stuff. And that's even if it's in your protocol, your protocol says, if this, then this. You have to have that experience to be able to say, no, maybe not. Maybe we don't do that right now. And sometimes it's actually really helpful to have at least one person on that crew that can kind of step back, as the saying goes, don't just do something, stand there, right? Just step back, take into account like what has happened, what we've done, what we've evaluated, going back to the communication we were talking about earlier, and put it together like, are we missing something? Obviously, sometimes you've got a lot of stuff going on. The patient I flew the other night, like where we had to change out the vasopressors, like we had a lot of stuff going on. That was a very active scenario, but it is helpful to take like just that quick breath and you and your partner look at each other, lock eyes, and be like, okay, here's what we have. Here's the primary survey. Here's what we've done. What are we missing? What else do we have to do? Do we need to do anything else? And sometimes just that quick recap. And I think they're even teaching that in the AHA classes now, that quick like summary recap during your resuscitation, like that is super important because you're right. You get into this momentum bias of, oh, we're doing this. Now we're going to do 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 this. And sometimes the right action for that patient is to do nothing. Give it a time for all of your actions to catch up to you. and then see where you're actually at and what you're dealing with. And you may find that you don't have to do something, or you may find that, okay, no, we do have to continue on this pathway that we were on, or we do have to do these other things that we were talking about. So absolutely, yeah, I completely agree with what you're saying, Holly.
The thing that I always think back to, because Jacob, I totally agree with you. I think sometimes we get so ingrained in like, do that and do that and do that and do that and do that. And then you see it all the time in like a ACLS code, right? Like you go in and you throw calcium, bicarb, EPIs, CPR, intubation at the patient, and all of a sudden you get ROSC and you're like, okay, what was the problem? And everybody's like, I don't know. Like they might have been acidotic, they might have had a tension, they might have been hypoxic, right? You don't know what fixed them. But what I think is so interesting to that point as well, Jacob, is, I think back to when I interviewed for my company, they give us a scenario, right? And the patient's initial blood pressure is like 75. And the paramedic that was in that scenario with me, he said, I knew you were an ICU nurse right away because we told you the patient's blood pressure was 75. And you're like, okay. Right. And it was like, it wasn't that I didn't care, but it was like, I got time. I got some time. Right. And I think to Jacob's point, you get into the back of the ambulance and you see this like hypotensive, tachycardic, trauma patient bleeding out. And everybody goes to push dose pressor, have to give a push dose pressor. The pressure's 60, get that blood pressure up. But next thing you know, your pressure's 75, but your heart rate's 180, right? And now you're bleeding out of whatever holes you can or cannot see at 180 beats per minute instead of 130 beats per minute. Whereas if you had stepped into the ambulance, taken a little bit of a survey, said, our pressure's low, we're definitely bleeding, give blood, you might have seen a better, more steady rise in blood pressure that's more sustainable than just a quick bump of epi, get them up, get them down kind of thing. And taking that time to think through, like, take a pause. What is causing the hypotension? What is causing the tachycardia? And addressing that first instead of just like deep diving into like throw everything you possibly can at them.
Absolutely, Caroline. Great point. And adding to it, we've all been there. There's somebody sick, something, things are happening. The patient's trying to die on you. And it's like, we got to do something. And the truth is, we are going to do something. We are trained to do something, but we want to make sure it's the right something. And that is key. And just taking that few seconds, communicating with your team, saying those thoughts that you're having out loud, and everybody just kind of going, oh, okay. We're all on the same page. And then, yeah, I feel like that opens up the possibility to have that right answer come up, and very quickly it kind of all comes together. Well, let me get back to our patient, because we've done some things. We've thought about some things. We were finally able to get them into the helicopter. We are now in flight. I'm going to say that we gave them some blood because that seems like a really good idea for this patient. And so we're going to do that. So we're in flight and the ventilator is just alarming, and it keeps saying high pressure alarm, high pressure alarm. You guys have also, with your blood, you put in a liter of LR. So you gave some fluids as well as blood. Just like I said, I really liked that. So we're doing that. You guys are adding to the scenario. Okay, here we finally get you some vital signs. I know y'all have been really anxious for these. They're not great. The blood pressure is 64/39. The heart rate is 132. Respiratory rate is 22 on the vent, and their SpO2 is 91. They're at an FiO2 of 100. So what considerations do you have next? Whatever you want to do. We want to, again, we're in flight so that, we're on our way. We're in the very small space with just a few of us. And so what can we do to maybe improve some of these vital signs? So I'm going to throw it to you, Jonathan, first. You get first crack at what would you like to do?
Oh, yeah. Well, it doesn't sound like this clinical course is going the way that we want it and heading the wrong way. Coming from an ER background and then getting into area, like everybody wants to assess your patient, but once they're in the aircraft, you really don't, sometimes you don't have great access to it. I mean, auscultation is not a thing, right? And so that's off the table. And so you're losing a few more of your abilities to be able to really thoroughly be able to look at the patient and be able to assess the patient once you get them packaged. And so to me, that was a learning curve coming into this industry of some of the spatial confinements that you have to be able to work in. And so you do have to learn how to use your vent and some of your other equipment to be more diagnostic for you in or out, since you are losing some of these abilities. And so one of the things that we would do is probably try to roll out the things that this blood pressure is awful. And so I'd be really concerned if they're intubated that they have developed a tension pneumothorax with the tachycardia and the hypotension. There's a decrease in the venous return, like Jacob was saying earlier. So I'm worried that that's the thing. And so this patient may be well on their route of getting a needle decompression in flight. So we can use the vent. And so we would check up a P-plat on this patient is what we would do. I would try to figure out if I'm getting these high pressure alarms is because there's something wrong with my airway, like maybe there's some sort of restriction on the ET tube, mucus, or, maybe a tracheal edema or something like that that's causing the high pressure alarm. Or is this more like a alveolar gas exchange compliance issue? And so the P-plat can kind of direct me one way or the other if I'm actually having ET tube problems or it's this pressure coming from something else. And so I would check a P-plat. I would start there. And if that seemed to indicate that there was increased interthoracic pressure, I would probably act upon that. We gave blood, so this patient's probably still bleeding. I'd continue some of those interventions that were already pre-mentioned, like, if they continue down that path. But that's probably where I would start myself.
All right. Caroline, what about you?
Yeah, I agree with Jonathan. At this point, I'm incredibly worried about a tension pneumo or a hemo pneumo, something like that. So I definitely want to look at my ventilator, see what numerics I can get off of that, what measurements I can get off of that. He also brings up a really good point about the limitations of being in the aircraft at this point. So the literature supports that a fourth intercostal space mid-axillary is going to be your better decompression site for a tension pneumo. But once you're in the aircraft, you may only be able to get to second intercostal midclavicular spaces. So you want to make sure that you're checking things off the list before you get to a point where you can't check it off the list anymore. Not that second intercostal space isn't still going to buy you some time, but it does limit you once you're in the aircraft. Once I've addressed that, if my vital signs still aren't improving, maybe my blood pressure's coming up, maybe my heart rate's coming down, I have a little bit better compliance on the ventilator, but still satin low. What can I do to can I ramp this patient a little bit? Are they backboarded? Do I have concern for spinal injury? Can I sit them up a little bit, ramp them up a little bit, get some of that pressure off the chest to come forward? We don't know anything about this patient. This is where my mind starts to wander and people get frustrated with me as I'm like, were they having an asthma attack and crashed their car, right? Do they need albuterol? And these are the things that you don't know because maybe that the patient was driving to get help to fix their respiratory issue or something. Thinking about the analgesia that you can give this patient. Are we giving just fentanyl or do we give ketamine that maybe has a little bit of bronchodilation properties as well? So kind of working through those modalities of it might not just be the ventilator, it might be a systemic problem too that's underlying that we haven't seen yet or we haven't determined yet. So just, throwing all the possible combinations of things at them in a systematic approach, right? Address the big thing first, which is most likely a tension pneumo. It's a blunt chest trauma. That's probably going to be your issue. But once you address that, once you fix that, maybe you have breath sounds back, maybe you have better compliance. Do you need a little extra PEEP? Do you need maybe an albuterol treatment? Do you need a little ketamine, a little MAG? But you want to make sure that you're systematic in it so you can check all the boxes and you can present the case to the trauma team to say, we've eliminated all these options. This is where we're at now.
Yeah. And I will say that there are some times when we've kind of knocked some of these things off. Now it's time to see if there is actually a zebra in this room.
Right, exactly. It sounds like hooves and it's probably horses, but it could be a zebra.
Right.
Stranger things have happened,
Agreed. What about you, Jacob?
Yeah, so I think actually, Caroline, I love where you went with that because there are three basic laws that govern everything that we do in especially transport medicine. Right? There is Occam's razor that says the simplest answer is probably the right answer. You hear the hooves, it's probably a horse. And then second to that, you have Hickham's dictum, which basically says that the patient may have as many malfunctions as they damn well please. So you hear hooves, it could be a horse, it could be a zebra, it could be both. So this patient may have blunt chest trauma and also a tension pneumothorax. And oh, by the way, they were also having an asthma attack. So absolutely, they can have as many malfunctions as they please. So just because they're a trauma doesn't mean, and I think reflecting back on my practice, I've probably been burned. The good question about what is the most commonly missed diagnostic finding in emergency medicine? And the answer is the second one, right? Because you're looking at an x-ray, you're looking for the pneumothorax. You find it, but then you miss the fracture. Or you're looking at your labs because you wanted to check the PaO2 and you see what it is, but you miss the fact that their lactate is 15. So you're right. You absolutely have to be systematic about it. And just because you found an answer, you can't stop looking. When I have time, I love to play that game of, cool, we're transporting this patient for this reason. What else is going on? Or like mentally, I like to play the game of, okay, they've told me this is a STEMI patient. I'm going to prove them wrong, because it makes you look at all of the other factors. It probably is a STEMI. You're absolutely right. Going back to Occam's razor, right? Simplest answer, probably correct. They may have something else going on. And then, of course, that third law is Murphy's Law, and I think we're all familiar with that. So getting back to our patient scenario, I think looking at this patient, looking at this high pressure alarm, hypotensive, tachycardic, I think if I don't have anything else available to me, empirically, this patient is getting 2 holes in their chest, one way or another, whether that's needle, whether that's a surgical finger thoracostomy. If you have the ability to do chest tube, I might do that. But this patient is a tension pneumothorax until that's ruled out. Now, if I have put my point of care ultrasound with me, and if you're credentialed and privileged to use that in your system, I can very quickly rule out a tension pneumothorax in about 20 seconds and like 4 breaths. Lung sliding present on the right, lung sliding present on the left. Guess what? This is not a tension pneumothorax. Move on to my next thing. Now we're thinking hemorrhagic shock. Now we're thinking something else. And likewise, you could complete that fast exam if you have the access, if you have the time and luxury, but this patient is clearly an extremis. What I'm using that for is I'm ruling out hytension. And if the patient has the windows, I might quickly look at a parasternal long or short and say, do I have a bunch of fluid around the heart that I need to drain with a pericardiocentesis? Like right there, I have potentially in under a minute, if you get facile with that machine, I have ruled out the things that I need to take immediate action on to save this patient's life. So I strongly advocate for the use of point-of-care ultrasonography in critical care transport and flight. I don't think it's something where we should be spending 5 minutes at the roadside before transport to do that. But when you have this guy right here who suddenly has a change, I'm assuming that this is sudden. It could very well be that these vital signs he's had the entire time, and we're just finally noticing them. But assuming this is a sudden change in his condition, now I'm looking to say, okay, is it these things? Because these require immediate action. And if it's not a tension pneumothorax and it's not a pericardial tamponade, probably got time to figure it out. And maybe it's just hemorrhagic shock, and we just continue the blood product resuscitation. Crystalloid, I guess, if you want to, if that might be all you have left at this point. And we're going to do a trauma stat alert to the receiving facility. And depending on your system, there's systems now where I can call this in, especially if I have a fast, and I can say I've got a positive fast, I've ruled out a tension, I've ruled out a pericardial tamponade, I'm hypotensive, tachycardic, I got a shock index of 2, and I've emptied my entire blood cooler already. We need to go to the OR, and they will say, cool, we'll meet you in OR 5. And you go directly to the operating room, don't pass go, don't collect $200. They just open this guy up and figure out what's going on. Very few systems are like that. So more likely than not, you're going to go into a trauma bay and get a trauma resuscitation. But you're absolutely right. You have to start thinking about all of those things, rule out what you can rule out. Yeah, if you can do a plateau pressure and see whether this is a resistance or compliance issue, maybe this guy's undersedated and he's just biting the tube, and that's why you got your high pressures, and that's just a red herring. So if you can do that, that's great. But you may not be able to reach the vent depending on where you're in the aircraft. So knowing your system, knowing what information you can get may help you to figure this out. But yeah, absolutely agree with everything that everybody else has said as well. But that's just kind of my diagnostic thinking here is take care of the stuff that's going to kill him. And if you can't definitively rule it out, empirically treat it.
One of the things I failed to mention earlier that I think we all would do this. Of course, I would start with making sure that there wasn't any displacement or anything wrong with my actual vent. Like you put them in the aircraft, next thing you know, you look over and there's a bag sitting on top of your vent circuit. And so those things would also need to be ruled out before I started stabbing holes in my patient. I would definitely make sure there wasn't something very, very obvious that caused this. Sometimes that patients don't like it whenever you cut off the flow off the vent circuit. They get a little angry with you. So, but
Low oxygen because it's not hooked up.
Yeah.
Guilty.
Yeah, we've all seen that. And if you've never been in that situation where you're trying to package and load a patient that's been intubated on a van or whatever's happening, it definitely, there's a lot of opportunity to displace a lot of things. IV lines, tubes, cannulas, things like that, chest tubes, like they all get yanked out when we're putting them in the aircraft. That's something that will come up. And so you do have to assess for those first before we act on the patient. But I think that's a give me. We all would have done that, but I love the other two answers as well.
Well, I think it's a good scenario to talk about because it actually came from things that I've heard some resistance to people wanting to get into the flight world about because of this discomfort of not having other people there on scene to help bounce ideas off of. But I think the conversation has been really good to talk through and say, yeah, there's obviously times when it could go many, many different directions, but getting back to understanding, having a good clinical background, being very adaptable in these situations, being willing to work with medic control or with your partner, and then also understanding that there are limitations in flight, such as oscillating the chest or things, but how do I work around that? Whether it's a point of care ultrasound or whether it's using different ventilator strategies to understand the disease process. So for me, as we were developing the scenario, it was really about trying to get back towards some of those concerns people have of being in the flight industry and not having the comfort level of making some of those decisions on their own. And I think a lot of you, I didn't want to start with that because I wanted to hear how it progressed, but I think a lot of the conversation has really supported the fact that being a strong clinician, being adaptable, and being able to look at things from various viewpoints very quickly and efficiently can bring a good positive outcome to a very bad scenario. So thank you so much. I know Holly wants to follow up with some professional development type questions, but thank you for giving all of your insight into that one. I really enjoyed hearing your different viewpoints.
I love a good scenario. And I also love it when there's like lots of different, not opinions, because truly you all had a very cohesive approach to it. You all kind of were thinking through different things. What are the limitations? What can I do? What can I rule out? What is possible for me to fix here? What do I need to alert someone like, hey, we're coming in. It's going to be kind of hot. Here's what we've got and here's what we don't. And here's what we need. And so really all of the conversation came back to a lot of communication and again being adaptable to your environment, which really goes back to our first question. I love this idea of sometimes I'm looking for that second thing. I'm not just going to let that first thing that we find be the only thing I'm looking for. I love that curiosity and I continue to like push yourself, which this kind of jumps right into my professional development topic, which is each of you holds multiple advanced degrees, certifications. I mean, there's lots of letters floating around between honestly, all of us in this call, but the number has significantly jumped having each of y'all on here. So there's a lot of ongoing learning. It's clearly a priority for each one of you. But I guess really my question is, why? Like, why do you believe the constant cycle of continuing education? You guys do volunteering, you're involved in professional organizations. Why do you think that it makes a difference in patient care? Is it more than just checking boxes? And so I'm going to toss this to Caroline first to lead off, but I'm really, truly interested in why you guys feel like this is important.
I consider myself incredibly lucky to have the resources that I do. Whether it be through ASTNA, through the BCEN, through the critical care boards, through my own medical directors, the people that I work with, people that I interact with every day. I consider myself very lucky to be able to use everyone and everything as a resource, right? I think if I emailed Jonathan tomorrow and I said, hey, how are you guys doing XYZ? He would email me back and give his perspective, and I could take that to my program and maybe inflict some change. I think the reason that it's so important is because not everybody has those resources. And I think, especially in our small communities, which many of us serve, we go into these small community hospitals or we interact with these ambulance crews. And I kind of touched upon this previously is, we are seen as a resource to them. I always think about, you get called to a scene run and maybe it's your third of the day and maybe you're tired and you're like, oh, this seems like so stupid. And I can't believe they would call me for this. And we got to do XYZ and they could have done that. But maybe it's that paramedic's first day on the job. Maybe it's their first arrest that they've ever worked. And you have to get into the ambulance and you want to show them like, hey, you've done a really good job so far. Let me show you some other things. And then they carry that into their next call. And then they carry that call into their next call. And next thing you know, you've spread enough knowledge that maybe they do learn how to run an arrest for an extended period of time without needing to call for a resource. Or you go to a community hospital and they've done something that is beneficial to the patient, but maybe not the best course of action. And you just go in, you say, really great job starting an epinephrine drip on this patient for hypotensive, sepsis, whatever. We're going to switch them to norepi because you get a little bit of both alpha and beta, right? And then maybe the next time that nurse takes care of a septic patient and somebody suggests epi, they say, hey, why don't we try some norepi? I've seen that used previously and it worked really well. And I think what's really cool about the extent of the reach that we have in our communities is that we can then share that knowledge with others and help build others up. It goes right back to what I was saying about don't be afraid to ask questions. I'll ask the dumb questions for you. You tell me your dumb question and I'll ask it because I don't care. But I want to empower you to be able to ask those questions the next time so you can help build your own career. You can help build your own knowledge base. And maybe you dive into something that you weren't previously looking at or looking towards because of the knowledge sharing that had gone on previously.
I love that. The idea that sometimes you need someone to lead by example, and one day you turn into the resource for other people. And that's just, I think all of us know someone who made just a really big impression on us when we were maybe first starting out in nursing, first starting a career, first starting out in like a new environment. And your hope is like one day I will be like that person for somebody else. And I think that is a noble goal to gain knowledge so that you can share it. So, all right, Jacob, I'm going to toss this one to you.
So I love that response, Caroline. I think that where I go with this is exactly a very similar location. So number one, networking. My father taught me at a very young age. He's like, a lot of things in life, it's not about what you know, it's about who you know. So getting the professional involvement with my professional organizations and getting involved in some of that, sure, you're developing resources for other individuals, but you're also networking, you're meeting folks, you're going to conferences, you're talking with other clinicians from around the country, around the globe even. You get to meet those people and exactly that. I've got a question. Hey, this came up. This was a pediatric patient. And I work for a program where we predominantly transport adults. We have a separate pediatric team from the Children's Hospital that does pediatric interfacilities at least. So we don't see kids a lot. So when we're talking about pediatric equipment, because we still do scene flights, I want to be able to reach out and like, hey, I know someone at this program. I can text them and see what they're doing about this, or what their thoughts are on that. Or I can I know one of the nurses from the children's team because we ran this scenario together, or we ran this flight together. I can send a text to them and be like, hey, what are your thoughts on this? Or I can reach out to my colleagues. I'm on the board of directors for ASNA right now as we're recording this. So I can reach out to all of the other directors from programs across the country and say, hey, do you guys have a policy for this? Do you have a procedure for this? Would anybody be willing to share what they're doing with this scenario? And I can get a lot of information very quickly from that. So I think networking is one of those. The other part of that, though, the continuing education, the professional development, going back to school for multiple degrees and obtaining multiple board certifications and studying for those board certifications. The other part of that, one of my colleagues in my current flight program, she has a morale sticker on her helmet, and it says, "No one is coming, it's up to us." And really, that is the embodiment of what we are doing. Because you can phone a friend, you can call medical direction and say, hey, this patient looks sick. And they're like, well, what do they look like? Well, they look sick. And sometimes you can't articulate it. Like, it's just that sixth sense spidey tingling. And it's like, this dude is sick. I don't know why. And you have to be able to understand and recognize what options you have available, what tools are in your toolbox. Going back to those 3 drugs we were talking about on this podcast, that's all you've got. It might not be 3. Like Jonathan said, it might be 60 drugs in your drug bag, but it's not an entire hospital pharmacy. So sometimes it may be, these are the resources I have. I'm in a cornfield and hours flight from the closest hospital. How do I make this work? And so a lot of that continuing education, the professional development is, at the end of the day, I am the last line between that patient and potentially the grave. And, not to overly dramatize everything, but quite literally, you don't have the ability to be like, oh, this patient's a cardiogenic shock. I'm going to call cardiology consult, come down here and see the patient. Oh, this patient's in hemorrhagic shock. We're going to get the trauma team involved. Eventually that'll happen, but they have to make it to that facility. And sometimes there's a lot of stabilization, and it may be, you might be at a hospital. And again, Cool. That's great. You're at a hospital. It's a rural community hospital. You can't call cardiology to come down because they're on call from home 3 hours away, or they don't have a cardiology service at that hospital. So you may need to do everything yourself. And that's where that continuing professional development comes in. You have to know your craft. You have to perfect your craft, because at some point, whether you're the resource for somebody else or you're just the resource for that one patient that's in front of you, you have to be able to look at yourself in the mirror and say, I did everything I could for this patient because nobody else is coming. It is up to me and my partner.
I like that a lot. I like that motivation sticker. There's a little bit of truth, and then there's just that little edge. And that's the kind of humor I like. And there's a lot of truth in there. But to your point, we all want to do the right thing. So we have to continue to grow our knowledge and our skills so that way we can know what the right thing is to do. And so you and Caroline have done great. So Jonathan, I'm going to toss this to you. Why are you back in school doing all the things, volunteering? What's that all about?
Dang, that's a tough act to follow, Jacob. Thanks for setting the stage for this one. Yikes. I want to echo a lot of what Jacob said and what Caroline said, that so much of being involved with professional organizations and getting certified is so much about building those relationships. And there's no way that I would be in my position in my career if I wasn't involved. Like, I get called by the chief nurse of the entire system to ask questions about transport, and they reflect on me as an expert. And a lot of that is because I'm credentialed as an expert. I spend a lot of time, I go to the conferences, I listen to what experts have got to say, and I take that back and I translate that into practice. Medicine changes so fast. But like, if you're doing what we were doing in 2019, then this is a totally different ballgame. Like, we do things a lot different. The interventions have changed. And you just can't sleep on that stuff. Medicine evolves very quickly. And if you're not talking to the people that are making those changes, then you're getting left behind. And ultimately, your patient is going to be the one who suffers for this. And so I had a lot of value in it. Studying for these certifications, I learned all sorts of weird tidbits of things that I've never been exposed to. Like, I didn't know about this pediatric rash, or I didn't know about this or this or this. And I learned about it. And I retained a lot of that, but I've also forgot a lot of that. And so I go back for these refreshers to keep my contact hours up. And I learned so much more as I go to it. Let's see value of that. And of course, one of my first conferences I went to, I got to see Jacob give a lecture on right-sided heart failure or pulmonary hypertension or something like that. And it just blew me away, because I've never even considered what pulmonary vascular resistance looks like, because it wasn't ever taught to me. And so as he's giving this lecture and being like, oh, dang, I've treated every PE I've ever seen wrong. And we changed the way that we do things. And so it's these aha moments that you get. And as far as being part of the ENA and ASNA and being active in these roles, I have so much fun meeting with these people and going out and doing it. That's really what I look forward to. Caroline says, my personality is a nurse, but these are the people I want to associate with. And I love it when we get together and we exchange war stories and experiences, and we can kind of bounce ideas off of each other about what we might think is the best thing. And I love that. I'm trying to finish up a research degree, because I really do feel like EMS is vastly overgeneralized into two modalities. And I don't think it's two modalities at all. I think you've got to look, is the value of a helicopter actually the helicopter, or is the value of the helicopter the nurses who are in it? And so whenever I look at that, I actually, in my experience, like, if we came by horse and buggy, that a lot of times will be better than the alternatives. Like, as long as I can get one of my crew members to this patient with their resources, I think we're going to improve outcomes. And I've got to have this network of experts to be able to prove this to everybody. Like, if we want to change something, I just can't anecdotally say, well, I saw this one time and this is the way it should be. Or what works here in Central Arkansas may not work in Cincinnati. You got to have this pool of experts and this pool of experiences to be able to kind of guide where we need to go. And without certifications, without the conferences, without being a part of the community, it's never going to happen.
So, Jacob, do you think you could just give us that right-sided heart failure lecture real quick? I'm just curious now what that's all about.
Oh, yeah, absolutely. Actually, it's really interesting, because the patient scenario that I flew yesterday, and actually, so strange that you bring that up. Literally, that was that exact scenario. Right, this was a guy who was in florid right-sided heart failure. We had to completely change up his treatment plan from the sending facility to find something that he liked to get him to the receiving facility. And interestingly enough, I'm actually driving downtown to give that exact presentation to our flight team as part of our education that we do every quarter. So come on down with us.
Well, that's awesome. And Jonathan, I really, appreciate all that all three of you said and being able to learn from each other, even, pulling Jacob into the conversation. There's things that I've learned from each one of you on this call from, Jonathan, Caroline, Jacob, even in the conversation we have in working together in different work groups or things. I think that there's a lot that we bring to the table, and being able to collaborate and being able to draw strength from each other, I think is extremely important. And so I appreciate each of you sharing those ideas. And one of the other things that I wanted to bring up on this call is something that we ask on all of the podcasts and something that I think is really important, and that is discussing the memorable times that we've had in our career. But, really looking more flight or transport specific, is there some type of patient transport, whether it's ground or flight, that really left a lasting impact on you, either as a clinician or as a professional? And maybe Jacob, we can bounce that back over to you first.
Yeah, so like two patients really come to mind here. And first of all, I have like this blurse, right? This blessing slash curse where I genuinely don't remember most of my patients. And I don't know why that is, but it's probably for the better, quite honestly. But I do have a couple scenarios that kind of come to the top of my mind when you ask like anything that has personally impacted me. One of those scenarios early on in transport, I was transporting this patient that was floridly hypotensive. They were on this medication I had literally never heard of called norepinephrine. Right, I was that new. And honestly, at the time, we weren't regularly using it in the emergency department, so I wasn't familiar with that drug. I'd been an ER nurse for many years, but that just wasn't part of our typical pharmacology. And I had no idea what to do with it. So I had to call med control. I'm like, this patient's on this med. Like, what do you want me to do with this? Like, that their blood pressure is still low. Like, what's the max dose? How do you want me to titrate this? So that really taught me that I need to know my stuff. I need to get out there and learn. I need to figure this out. And that sharp learning curve that I was talking about, that's right where I realized, what am I doing? And then shortly thereafter, there we had some ICU transfer again, weird things that I had never seen before. And then the second patient that I think of is a patient I was actually, technically it was a transport patient, but I actually started out in the emergency department because my first flight job, you were an ER nurse and you were on call for flight. So I was working in the ER in the resus bay, but I was also carrying the flight pager that day. So it was a STEMI patient that came in. I was attending that patient in the resus bay as the ER nurse, but I was also carrying the flight pager. And because this patient was a STEMI, I knew that I was going to be flying him as well because I was at a hospital that did not have a cath lab, it was a community hospital. So I'm taking care of this patient, typical STEMI stuff, nitro, aspirin, heparin, bolus, all those things as the flight tones are dropping. And I'm sitting there and I don't know what caused me to do this, but it's a good thing I did. I have the heparin drawn up in the syringe and I just happen to ask the patient, hey, by the way, any recent bruising or black stools or anything like that? And the patient says, actually, yeah, I've had these really dark black stools for the last several days. I paused. I didn't give the heparin. Obviously, we didn't have any labs back yet. So we fly this patient to the receiving facility. As we land at the receiving facility, I get a text from the ER doc at the sending that I was working at. And it said, can you pass along patient's hemoglobin was like 5 or 4 or something like that. And come to find out, getting follow-up on the patient, clean coronaries, literally profoundly anemic, caused an infarct that we were seeing on the EKG. So just going back to what we were talking about before, right? Patients may have as many problems as they darn well please. Sometimes you do have to pause and ask those questions. And I think both of those were very valuable learning points. Number one, no matter how much you think you know, you don't. Keep learning. This is literally a lifelong learning profession to be in. And number two, your patients may always surprise you. Looks like a duck, quacks like a duck, waddles like a duck, turns out to be a platypus. So you may have a textbook presentation in front of you that was just taken out of the wrong textbook that you thought you were reading, and turns out it was something completely different. So always try to learn from every single patient encounter.
Yeah, great points, Jacob. Thank you for sharing those too. Jonathan, how about you? I know you've got some crazy stories that you've had to deal with in your career. Anything stand out?
Yeah, I know, kind of echoing, I got a couple of them that really two opposite ends of the spectrum. I can remember after getting my board certification in flight and critical care and just really feel like I was really on top of my game. I was real sharp. I got the opportunity to transport a patient that had an open chest and pacers and 5 or 6 drips and just all the things going on. It was super complicated. And the patient was decompensating at the ICU sending facility that they came from. And then enter me and my team, and we were actually able to come in and intervene, change a lot of things up, and stabilize this patient and deliver them in a much better condition than what we found them. And I walked away from that transport being like, dang, that really felt good. I really feel like I did some good work today. I was very pleased with myself. And so I kind of carried that around, this confidence that went with me for it. But unfortunately, whenever you have those great days, a lot of times you'll find that you wind up getting humbled on the next flight. And so I think maybe the next 2 or 3 days later, I was involved with it was a rural Arkansas in the middle of nowhere. Some kids in the back bed of a pickup truck run off the road and ejected all 3 of them onto the road. And the responding unit, the ground unit that responded to it had a EVO, which is something we have here in Arkansas, which is an emergency vehicle operator, which is less than an EMT, and then an EMT. And so that was the people for this mass casualty, pediatric. And so we get there and I triage these kids and I take the sickest one. The GCS was in the dirt and they were decompensating. And my paramedic partner, we go to RSI this kid and the pressure tanks and he misses the airway. And he tries again to miss the airway. And so then I get over here and by the time I get to his airway, this airway's bloody, it's mangled, it's nasty. I go to look and I can't see anything. And like this kid is on the verge of dying. And so I somehow miraculously got this airway to stick on this kid. And I walked away being that was almost this catastrophe that happened to me. And it just really being like, man, we really screwed up. Like we took this kid's airway away on purpose and then couldn't get it back. And I just felt like everything just went wrong. And I was just like, I've caused this anoxic brain injury from this prolonged RSI procedure or something. And so that humbling experience really, it stuck with me. And so you guys were talking earlier about you feel the need to do something, that action bias. I feel like this need to act. And so I think I learned a very valuable lesson that day, being like, I got the cart before the horse and got in here and we really got ourselves in trouble. And so I do remember kind of both those scenarios. I'm with Jacob. I do forget a lot I only remember the really bad ones. A lot of the flights go the way they're supposed to go and they just kind of disappear into the background. But those that just do not go your way are pretty awful. If you've never been there before, standing over a patient, feeling like you failed them in the back of an ambulance somewhere, it's an awful feeling and it's a horrible experience that does stick with you a little bit.
Definitely. It definitely is. And Caroline, I've heard you present on a unique scenario that you dealt with. I don't know if that's what you're wanting to share or something different, but why don't you go ahead and let us know a little bit about some of the crazy experiences you've had as well.
Boy, I'm like sitting here racking my brain. What's the most memorable patient I've ever transported? And it's hard to pick just one. I did present on a patient. We were called for a pediatric medical patient. It was a scene run, middle of the night, 3 a.m., didn't know where we were going. Wound up being a home birthing center that we showed up and the baby had already passed at that point. And then someone looks in the bathroom and there's mom hemorrhaging, right? So that shift in modality of like, oh, I was going for a peds and now I'm dealing with obstetrics. That was definitely a very memorable flight. You know, I don't want to spoil the ending or anything, but you know, it's those patients where you have to change gears rapidly and really rely on your education. You know, I was thinking about a transport that I was involved in a couple years ago. It was a vehicle across the center line. We got on scene and we were told that there was a fatality in the vehicle. It was a child was found under the dashboard in arrest. Ground crew scooped her up and started going to the adult trauma center with her because it was the closest. And we wound up in the back of the ambulance with the mom who was sick, but she was awake and she was talking to us. And we were only a couple minutes from the adult trauma center by air. And so we said, this is a scoop and run. Like, let's just go. Vitals are stable. Let's get out of here. And we landed at the trauma center and we were walking to the trauma bay. And I remember I had an orientee with me. So I had them at the foot. My partner was at the head of the stretcher. So I was able to walk alongside the stretcher with the mom. And she was a little anxious. She's talking to me and she said, I'm scared. And I looked at her, and this is my fatal flaw in nursing is like, I'm a sympathy crier, right? So I was like, oh God, please don't cry. I'm going to cry if you cry, don't cry, right? And I looked at her and I said, I'm very scared too. I said, I'm very worried about you. I think you're very sick. Going to be a lot of things that are going to happen very quickly, but they're going to take really good care of you here. And so we get her into the trauma bay. And as they are intubating her, the next trauma bay over is where the child was. And they said, we got pulses back on this child. Can you take her to the pediatric trauma center? And so immediately you have to switch gears and you're like, okay, mom's dropped off, mom's in the hands of capable people. And I said to them, here's my communication center, call them, tell them this is what's happening. I called my pilot. I said, can you get me to this hospital? They said, we got the fuel, tell me what you need. And we're very lucky that our pilots are well ingrained in what we do. So I said to him, I was like, bring me my ventilator, bring me the orange bag, bring me this bag. And so he comes walking in with all this stuff. And by the time he came in with the rest of our stuff, we had the child mostly stabilized, packaged, and we were able to scoop her up and get her to the pediatric trauma center. The kicker, of course, being that a couple days later, she did end up passing. But what was really interesting is the family was friends with someone that worked at the airport that we were based at. So a couple weeks later, we get this giant fruit basket and this beautiful card that said, by name, each of us that was on the flight, thank you so much for taking care of our loved one. It wasn't the outcome that we hoped for, but here's how mom is doing. We got a big update on how the mom was doing. You're in our prayers. Thank you so much. Things like that. And I think the patients that end up sticking with me the most are the ones that look me dead in the eye and say, I'm scared. Because it really brings you back to that base nursing compassion that I harp on, where it's okay that you're scared. It's okay that I'm scared, but I'm going to take care of you to the best of my ability. I'm going to get you the help that you need. And we're going to make the best of a really bad situation. And kind of coming back to Jonathan's point about being humbled by patients, or Jacob's point about advancing your career and advancing your knowledge to take care of these patients. The patients I remember the most are the ones that I think looked at me at the end of the day, or looked at my team at the end of the day and said, that person really helped me when I needed help.
Wow. You guys, I can see why they have all impacted each one of you in different ways, because just hearing your stories, I'm like, oh, that was good. That was good. And I find it interesting. And to your point, there's a ton of patients that I don't remember. There's a ton that everything went well, or it was a routine enough that it was kind of wiped from my memory banks. But then there are times when there's just, I may not remember exactly, but there is something about their care, whether it be that personal connection that I had with them. Maybe it was that things went horribly wrong. Maybe it was that things could have gone really horribly wrong, but for whatever reason, they just kind of stick with you and they become the reason that you want to continue to grow, right? They are motivation, because you're like, look, or I will never be as unknowledgeable or unfamiliar as I was that day. And it kind of helps to motivate you to oh, I'm going to read up on that. I have always found is motivation to continue to grow. And so thank you guys all for sharing that. I know it can be hard to sometimes revisit some cases. It can also be really rewarding to kind of sit there and think about it. And I love exchanging, as Jonathan put, those war stories. And I truly believe nurses are just really great storytellers. So I love hearing nurse stories. And so again, thank all of y'all for sharing that.
Something I think is kind of an interesting, me and Jacob and Caroline talking about these patients that kind of fade off into the background and aren't memorable for us, because this was just your standard STEMI that had the predictable course, that they got to the cath lab and they had a good outcome. And for me, I don't remember them or anything about it. It was just routine. But could you imagine from the patient perspective of having this catastrophic cardiac event and all of these things and getting thrown into the back of a helicopter and transported halfway across the state? Their experience is a lot different from my experience. I don't remember it because it went the way it was supposed to, but this patient, this was probably the biggest event of their life. And we take that for granted a lot. And so I really appreciate Caroline talking about that nursing compassion and that relationship, because even I get away from that a little bit and I do lose focus of some of that. And I think I hate to go back to the word complacency, but it's just because it is routine. And you do forget, these are people, these are souls that we are transporting and saving. And it is a big deal. If you're in their presence, if Jacob Miller shows up to your bedside at a hospital, this is serious. This is a serious event this patient's going through. And I think that gets minimized a little bit. And I think I'm guilty of that. So I really appreciate the context, Caroline, that really hits home.
What I love here is what's normal for the spider is chaos to the fly, right?
Yeah, I always think about you might not be the only STEMI I've ever taken care of, but I'm going to be the only flight nurse you ever meet. You know what I mean? So it's hard to remember how small our world and our network actually is when you're in it. But when you meet those people that are like, wow, a flight nurse, you get in the helicopter, that's amazing. And you may never see me ever again, but I might be the only person that you ever remember as the person that took care of you. So I want to make sure that it's a good impression, I guess.
No, I totally agree with you. Okay. I have some last questions for you, and they are supposed to be rapid fire. So heavy off the unmute. We're ready to go. And I'm going to kind of go in a circle. So my lead off, Jacob, you'll lead off. Caroline, you'll follow up. Jonathan, we'll circle like that. And these are rapid fire. I always say this is the fun part, to which Michael never gets to do this. So you guys, I get the fun part. Okay. So I have some categories. I tweaked them a little bit for this podcast because I wanted to bring in some different elements. But okay. Favorite must have to bring with you on a long shift?
Mackies, obviously.
Okay, let's go. Snacks, it is. All right. It's very specific, and I like that. All right, Caroline.
I'm going to get even more specific. There is nothing that the little short 90-calorie Coca-Cola full-fat soda can't fix at 3 a.m.
I am a Coke Zero fan, but I will go with that. There's nothing that a Coke Zero or Diet Coke could not fix. Go, Jonathan.
Oh, coffee. I'm a coffee guy. Like I love snacks, but if I had to pick between coffees or snacks, it's going to be coffee. It's going to be caffeine. I got to have it.
That's fair.
Yeah, I will always have a snack in my bag, but I do fall into the caffeine line. If I had to choose one, I need you to mainline some caffeine to me. Okay. All right. Favorite song to get you pumped up for a difficult stretch of work? Jacob.
I have radio ADD, so it all depends on which personality is driving the car that day. So it could very well be classic rock, modern rock, country, Pink Floyd. Literally anything is pretty much on the table with the exception of talk radio or opera. I'm not a big opera fan, so even a classical will make an appearance once in a great while.
I like that. Caroline.
Boy, I'm going to blow everyone's mind here because I also have musical ADD sometimes, but I will say, boy, you throw on like a little bit of like classic hip hop or like a little bit of like hard rap, like Cardi B, Lil Kim, those are my girls. I'm in for it.
Let's go. All right. I'm with you. Jonathan.
Nobody probably ever heard of it. It's a LCD sound system, Dance Yourself Clean, but it's a fun one if you haven't done that yet.
You guys, I fell hard into like 90s alternative. I'm not sure what started it. My husband was like humming a song and I'm like, what is that song? And so Sunday we were on the road and I'm just like, I haven't listened to music like this. Where I felt like I was in a time warp. And then you remember like how many lyrics live silently in the back of your brain that you haven't accessed in like 10 to 15 years, but all of a sudden it's like right there, very easy. I'm like, I can't remember stuff that I studied for. But yet this lyrical genius lives in the back of my brain. So
Holly, I just have to point out that the 90s was not 10 or 15 years ago. But
shut your mouth, Michael Baxter. Shut
there.
your mouth. Look, math doesn't apply to things like music. Okay. And I absolutely refuse to agree with this. No, the 90s were literally just yesterday. So, shush your mouth. Next thing you know, they're going to be playing like Cardi B on the oldies. Can you imagine that? Like,
we got to get back into rapid fire.
Very
anyway.
nice.
I know. Okay. Yes. Okay. Rapid fire. Here we go. Huh. Best description you've heard of flight nurses are like.
So I had to actually like Google this because I haven't heard that expression before, but I saw a Reddit post that said flight nurses are like the special forces of nursing. And I actually kind of like that. When I just thought of this though, I was thinking flight nurses are like feral raccoons. So I don't know how you like reconcile the two of those together, but I guess the feral raccoons of special forces. How's that sound?
I feel like you've kind of captured the whole industry. So, wow, Caroline.
Mine isn't necessarily like flight nurses are like, but I will say for the last several years, I have had very small on my helmet, my name, and then it says dumpster fire right under it that my mechanic put on there many, many years ago. And he was like, it just seems like you get into a lot of stuff. And I was like, yeah, that's accurate. And I always tell people now, for whatever reason, the first shift that you ever work with me is always the worst. And then after that, it's fine. But like, we're going to get into some stuff on the first shift and then it's going to be fine after that.
Well, you've got to prepare them for the feral raccoons that are going to run around in that dumpster fire for a little bit. So, all right, Jonathan.
Jacob kind of stole my thunder because I was going to say caffeinated feral cats, but I do have a saying that we use in our program that I think is pretty funny. And so I'll say, so how do you know that you're talking to a med flight nurse? Don't worry, they'll tell you.
Oh,
Don't worry. They'll let you know.
don't worry. I'll let you know. I feel like we've really defined flight nurses. Thank you guys for that. All right. This is another one. What is something that helps you reset after a tough transport or a tough shift? Jacob.
So I think like discreetly in the moment, going, especially if we go back to our base hospital, going to the EMS room, peanut butter and jelly, Uncrustable, amazing. Just sit there, love the Uncrustable, love the snacks, right? I don't know. It's just a theme, I guess. But I think more long term, my reset button is nature. So hiking, especially some kayaking, but just like getting out of nature, being by myself, throwing the Bluetooth earphones in or not, and just like jamming out to some music or just sitting there in complete peace and quiet, all by myself with literally nobody else around me. That is my reset button.
I love that. Caroline, what for you?
There is nothing that a mini 90-calorie full fat Coca-Cola cannot fix at 3 a.m. I would say that's my like go-to after a tough transport. If I just need to decompress, maybe talk to my partner, how you feeling? How am I feeling? That kind of thing. After a tough shift, nap queen. I love to nap. Just take a quick little nap, reset for the day. I like to do things like Pilates, get outside, walk, just hang out with my friends. Sometimes it's nice to get outside of the HEMS world. A lot of my friends that I'm very close with do not work in nursing. So it's nice to kind of go out to dinner and just talk about the workout class that you took or your boyfriend problems or whatever it may be, and just kind of remove yourself from the medical world. Because like I said, at the end of the day, I fully admit nursing is kind of my personality, but sometimes I need to step away from that just so I can be like, oh yeah, I do other things too. Plus my little 90-calorie Coke.
She stands by it.
I stand by it.
Mm-hmm. Jonathan, what about for you?
I don't know. I feel like at work, it's really, really overstimulating a lot. Phones ringing, you never really get any rest. Like if you do have some downtime, you are napping. It's not like you really get any peaceful sleep or anything like that. It's like sleeping on eggshells or something. So for me, after being overstimulated for my entire shift, I live an hour away from work. And so I will drive home in absolute and utter silence and not say a word. I won't answer my phone. I will just literally drive home and just be in the road and kind of file those thoughts away and those emotions or whatever happened that day. So I think that alone time to let me kind of process what I've experienced is important to me, I think. And I used to whine about living so far away from work, but it's actually turned into like a little therapy session because it gives me time to really decompress, and then I can kind of wash my hands of the day when I get home and can come back to my family and do my thing. I'm not still revved up from work a lot of times. So be mine.
Yeah, I like that. And I like that people can decompress in different ways, but nurses in general, healthcare people in general, do not do such a fantastic job of taking time to actually do that. So I think it's important that once you figure out what it is, those things that really help you come back to yourself and decompress and reset, I think it's important that you make time to do that. Because it is, there's always patients, there's always something to do, there's always the next thing. And if we don't prioritize it, then we won't do it. And we need you guys to last a long time, be out there saving lives. So, all right, this is my last question because people do like the social media thing, to Caroline's point, and they probably would love to be able to reach out to you guys. So if our audience wanted to follow you online, are there social media platforms or some way that they can reach out to you? I'll start, Jacob.
Yeah, so I'm on most of the socials, Facebook, LinkedIn, X, Blue Sky. My handle on all of them is Jacob Miller, ACNP. That stands for Acute Care Nurse Practitioner. So Jacob Miller, ACNP on all the socials, or if you want to shoot me an email, jacobmilleracnp@gmail.com. By all means, feel free to reach out.
Awesome. What about you, Caroline?
If you want to see pictures of cats and helicopters, you can follow me on Instagram. It's Caro Levin, CAROLEVIN 119. And then if you are not into cats and helicopters, your choice, you can shoot me an email. That's clevin119@gmail.com.
Awesome. All right. Jonathan Baxter.
Yeah, I'm not really hip. I don't do a lot of the social media stuff. So if you want me, by all means, please shoot me an email. My email is baxtersword@gmail, BAXTERSWORD@gmail.com. I'll be happy to respond to you.
Awesome. Well, thank you guys so much for sharing that.
Well, whether you are identifying as a feral raccoon or a dumpster fire or a silent resetter, for each one of you that's on the call today. I really appreciate all of you taking the time. I know we've recorded for a long time, but it's been really great having your insight, being able to bounce around clinical, ethical, professional ideas and questions with each one of you and hear your thoughts on those. So thank you so much for taking the time. And our goal with this is to improve the world of nursing and hopefully give some people that are interested in flight nursing an opportunity to really consider the industry in more depth and detail. And I think each one of you has really articulated a lot of those concepts well. So thank you so much for being on the podcast. We really appreciate it.
Yeah, thanks so much for the invite.
Yeah, I'm really flattered to be here. Thanks so much for the invite.
Yeah, I appreciate everything that the BCEN does for us, and thank you for having us.
Well, I want to take this time to thank Jonathan, Caroline, and Jacob for joining us for this two-part episode of BCEN and Friends. Thank you all for generously sharing your expertise, your experiences, and your unwavering passion for flight nursing. Your commitment to lifelong learning, professional growth, and excellence is shaping the future of the air transport field and setting a high standard for others to follow. Time and again, you've answered the call, making a profound difference in the lives of patients, families, colleagues, and fellow nurses. We are deeply grateful for everything that you do and the remarkable impact you continue to make. And to all of our listeners, stay tuned as we bring new, insightful episodes of BCEN and Friends. If you have a suggestion for an episode, we'd love to hear it. You can send us a message to bcn@bcn.org. I'm Holly Briggs here with Michael Dexter. And on behalf of the entire BCEN team, we thank and celebrate you for all that you're doing as professional nurses across the emergency spectrum. Until next time, we are out.